A very good morning to everyone present. My name is Diya Sandesh Rathod and my topic is anti-tubercular drugs. So, first of all, what is tuberculosis? Tuberculosis is a chronic granulomatous disease which is a major healthcare problem in developing countries. According to WHO statistics of 2014, that is World Health Organization, 9.6 million cases have been recorded globally, among which India was the highest contributor with 2.2 million cases. So, tuberculosis has always been a great problem in our country. The revised National Tuberculosis Program, which was launched in 1997 by the Indian government, makes policies regarding the treatment of tuberculosis, and it has revised its guidelines in 2016. So, what is the etiological agent of tuberculosis? It is Mycobacterium tuberculosis. Due to the spread of HIV in recent times with high prevalence of tuberculosis and Mycobacterium avium complex infection, the course of treatment of TB has become really extensive. Emergence of multi-drug resistant TB, MDR-TB, due to resistant to the antibiotics which are used in the treatment of TB. So anti-tubercular drugs are classified primarily into two types, which is first-line drugs and second-line drugs. First-line drugs has a mnemonic which is HRZES. So the H consists, H means isoniazid, R rifampin, Z pyrazinamide, E ethambutol, and S streptomycin. The second line drug consists of fluoroquinolones, ofloxacin, levofloxacin, moxifloxacin. Other oral drugs are ethionamide, prothionamide, cycloserine, terazidone, paraminosalicylate acid, rifabutin, rifapentin. Injectable drugs are kanamycin, amikacin, capreomycin. Alternative grouping done for anti-tubercular drugs consists of 5 groups. The first line oral drugs are the most potent and best tolerated drugs used in treatment. Thereby, every doctor attempts to give this drug for the first course of treatment as soon as the patient comes. It consists of isoniazid, rifampin, pyrazinamide, ethambutol. The group 2 drugs are injectable drugs, streptomycin, kanamycin, amikacin, capreomycin. Group 3 are fluoroquinolones, ofloxacin, levofloxacin, moxifloxacin, and ciprofloxacin. Group 4 second line oral drugs, ethionamide, prothionamide, cycloserine, terazidone, PAS, rifabutin, rifapentin. Group 5 other drugs which have unclear efficacy and are used as reserve drugs and should be avoided in cases of MDR-TB, bedaquiline, clarithromycin, clofazimine, linezolide, coamoxiclav, imipenem. Among these all, only group 4 drugs are bacteriostatic, rest all are bactericidal. Moving on to the first among the anti-tubercular first-line drugs, which is isoniazid. The full form is isonicotinic acid hydrazide, INH. Highly effective, widely used. It is the cheapest anti-tubercular drug. It has tuberculocidal action. It is a first-line treatment drug. Mechanism of action. Isoniazid is a prodrug which, when enters the mycobacteria, converts into an active form by catalase peroxidase enzyme and inhibits the synthesis of mycolic acid. INH has primarily two sites of action, which is the INHA and CASA gene, which are the two products which are involved in the synthesis of mycolic acid in the mycobacterium cell wall. So when INH acts upon these two target sites, the death of bacteria occurs as it inhibits the cell wall synthesis. Pharmacokinetics. It is metabolized by acetylation. Our population consists of two types, slow acetylators, which is 60%, and fast acetylators, 40%. Drug interactions. Aluminium hydroxide inhibits INH absorption. INH also retards phenytoin, carbamazepine, diazepam, theophylline, warfarin metabolism by inhibiting CYP2 C19, CYP2 3A4. Adverse effects: peripheral neuritis, neurological manifestations like paresthesia, numbness, mental disturbances, convulsions. Hepatitis, common in alcoholics, lethargy, rashes, mild anemia, arthralgia. Uses: first line drug in the treatment and prophylaxis of tuberculosis. Moving on to the second drug, which is rifampin or rifampicin. It has bactericidal action. It is obtained from Streptomyces mediterrani. It interrupts the RNA synthesis by binding to the beta subunit of mycobacterial DNA-dependent RNA polymerase, which has been reflected in this diagram. Pharmacokinetics: it is well absorbed orally. Bioavailability is 70%. Drug interaction: it is a microsomal enzyme inducer. It enhances its own metabolism. Adverse effects: hepatitis, cutaneous flushing, flu-like symptoms, chills, fever, headache, malaise, abdominal cramps, nausea, vomiting. Uses: it is used in a treatment of TB, tuberculosis, leprosy, meningococcal meningitis, and MRSA, methicillin-resistant Staphylococcus aureus. The third drug, which is pyrazinamide. It is a bactericidal drug similar to INH but weaker in action and more active in acidic medium. Mechanism of action: it inhibits mycobacterial acid biosynthesis. It inhibits mycobacterial mycolic acid biosynthesis by converting into an active metabolite encoded by PNCA gene. Pharmacokinetics: it is absorbed orally, widely distributed, and has good penetration in CSF. Adverse effects: hepatotoxicity, contraindicated in patients with liver disease, hyperuricemia, flushing, and rashes. The fourth drug is ethambutol. It is a selectively bacteriostatic drug, which is the only differentiating point between ethambutol and other antitubercular drugs, as other antitubercular drugs have bactericidal action, which acts by killing the bacteria, and ethambutol is bacteriostatic, which acts by inhibiting the growth of the bacteria. Mechanism of action: inhibits arabinosyl transferases, thereby interfere with mycolic acid incorporation in the mycobacterial cell wall. Pharmacokinetics: 3/4 oral dose absorbed, widely distributed, penetrates meninges inconsistently. Toxicity: loss of visual acuity, color vision field defects due to retrobulbar neuritis, contraindicated in younger children. Adverse effects: nausea, rashes, fever, peripheral neuritis. Moving on to the last drug among all the first line antitubercular drugs, which is streptomycin. It is a aminoglycoside antibiotic, bactericidal drug, active against extracellular bacilli in alkaline pH, not effective orally. Adverse effects are ototoxicity, nephrotoxicity, neuromuscular blockade, and it is contraindicated in pregnancy. Also, this is an injectable drug and cannot be used orally. The doses of all the drugs have been mentioned in the table. Finally, I've prepared a summary for all of the drugs. The first column consists of the mechanism of action, whether it is cidal or static. Second consists of whether its action is occurring on intracellular or extracellular bacilli. Third, the degree of hepatotoxicity. Fourth, whether we should reduce the dose in cases of renal failure. And fifth, its relation in pregnancy, whether it is safe or contraindicated. So the first drug H, which is isoniazid, it has cidal action, acts on both bacilli. Hepatotoxic, no reduction in dose in renal failure, safe in pregnancy. Rifampicin has also the similar action. Pyrazinamide, it is acting only on intracellular bacilli in acidic pH. It is very hepatotoxic, the most hepatotoxic among all. We should reduce the dose mildly in cases of renal failure. Fourth drug, ethambutol, it has static action, and this is the only drug which has static action among the other drugs which have cidal action. That is, it acts by inhibiting the growth of bacteria. It acts on both the bacilli. It is not at all hepatotoxic. We should reduce the dose in renal failure. It is safe in pregnancy. Fifth drug, streptomycin, it has cidal action. It acts only on extracellular bacilli in alkaline pH. It is not hepatotoxic, and we should reduce the dose in cases of renal failure. It is contraindicated in pregnancy. So the final segment, which is MCQs. Question number 1. First line anti-tubercular drugs include all of the following except. So the mnemonic which we learned for anti-tubercular drugs is HRZEX, which has been given here. So the drug which is not a part of this is ciprofloxacin, which is the correct option. Question number 2. Rifampin kills tubercular bacilli by. The mechanism of action of rifampin has been shown in this diagram, which shows that rifampin acts by interrupting the RNA synthesis and inhibiting the synthesis of mycolic acid by binding to mycobacterial DNA dependent RNA polymerase. So the correct option would be 1. Question number 3. The characteristic toxicity of ethambutol is visual defects, contraindicated in younger children, and had a toxicity of loss of visual acuity. Fourth, which anti-tubercular drug is not hepatotoxic? Ethambutol. Ethambutol and streptomycin are not hepatotoxic, and among these options ethambutol is present, so that would be the correct option. So the last MCQ, what is true for isonicotinic acid hydroside? An active transport mechanism concentrates INH inside sensitive mycobacteria. True. Sensitive mycobacteria generate an active metabolite of INH through a catalase peroxidase enzyme. Also true. The most common mechanism of INH resistance is mutation in the target gene, which encodes for a specific fatty acid synthase enzyme. False. So the correct option would be both A and B are correct. Thank you.